The last section we want to talk about is management and maintenance of the airway, troubleshooting, and a quality improvement process. If you find a condition where you're unable to ventilate at all with the Combitube, the tube does not produce chest rise, there's absent gastric sounds, you lack bilateral breath sounds or detection of CO2, immediately fully deflate both of the balloons, remove the Combitube, and reinsert an OPA and resume two-person bag valve mask ventilations prior to reattempting the procedure. If ventilations are successful through blue tube, tube number 1, and an air leak is detected at the mouth, you may place additional air into blue port number 1. You should do this in 10 cc increments while ventilating, up to a maximum of 85 cc's for the Combitube SA, until that air leak resolves. If the air leak does not resolve, you should deflate both cuffs completely, remove the Combitube, go back to VVM and an oral airway until you can secure another advanced airway. Airway management decisions as related to the Combitube SA. The Combitube SA is intended to be a secondary airway for cardiac arrest patients. The iGel will remain the primary airway. If it fails or you have other problems, you may use a Combitube as a backup. We think the ease and the speed of insertion allow for very minimal interruption during CPR. As always, a definitive airway should be placed prior to any IV access in the adult cardiac arrest. BLS airways are probably still preferred in the pediatric cardiac arrest, however. Patients in respiratory distress or respiratory arrest, which include patients who are apneic or have some degree of respirations but clearly without a gag reflex, the practitioner is able to pick from any of the approved advanced airway adjuncts. That includes the Combitube SA or the iGel or endotracheal tubes. As with the implementation of any device, the county PSRO board will track the airway use, whether it's for respiratory arrest or cardiac arrest. Documentation points are required under the protocol include the size of the airway, the time of the attempts, the number of attempts to place the airway, any suctioning that's required, the ventilation compliance, chest rise with ventilation, that capnography was used, and what that capnography reading was, the quality of your lung sounds, the absence of any epigastric sounds, what method you used to secure the airway, in the Combitube, specifically which tube was used for ventilation, if gastric decompression was performed, and any complications you may have had with the procedure. We'll look at each chart and make sure that all these points are met. So in conclusion, I think the Combitube SA will provide a rapidly insertable supraglottic airway requiring less procedural steps to properly engage the pharyngeal structures. The Combitube should be a backup airway placed in a cardiac arrest patient and is certainly selectable as the primary airway in respiratory arrest patients. If you have any questions about the in-service process or this slide set, you may contact Bob Hale, the EMS Clinical Coordinator.